Hi everyone, thank you for joining me today. My name is Sergio Sposato and I'm the Principal Clinical Psychologist for SLAU Treatment Advice and Recovery Team and for Wakefield Inspiring Recovery and Inspiring Future in Turning Point. This webinar has been designed to increase awareness around alcohol and mental health. We will start by looking at current data around alcohol use in the UK before exploring the reasons that lead clients to start drinking, how the drinking patterns are maintained, and the associated risks. And we finally explore the current treatment challenges related to people who are drinking and presenting at the same time with mental health problems. Alcohol consumption in the UK represents a big paradox. While over the past years we've seen a huge number of people moving towards abstinence and reduction, the number of people drinking above dangerous level has also increased. Understanding these trends will help us understanding the clinical challenges of alcohol use disorder. Recent surveys reveal that 77% of the UK adult population consumes alcohol, though drinking behaviours are noticeably changing. Approximately 24% of adults in England now report no drinking alcohol at all, representing a significant increase from 2022, while 30% of adults continue to exceed the recommended daily limits, which means drinking more than 3 units for women and 4 units for men on a single day. Women are slightly more likely to abstain compared to men. But there are also regional disparities, with the West Midlands and London demonstrating the highest proportion of non-drinkers, and North East England features the lowest rate of abstinence. Among those who drink, 81% consume alcohol within the Chief Medical Officer's low-risk drinking guidelines of 14 units per week. And 90% report to actively attempting to moderate their intake, utilizing strategies such as scheduled drink-free days or transitioning to low-alcohol and zero-alcohol alternative products. There are multiple reasons prompting clients to reduce or stop their alcohol use. And while health concerns and advice from health professionals remain important, recent analysis indicates that the cost and social factors have nearly doubled as primary motivation for consumption reduction. Despite this encouraging shift towards moderation, a substantial cohort continues to drink at high-risk levels. The high-risk behavior is most prevalent among individuals aged 55 to 64 years old. Men living in Yorkshire and Humber are the most likely demographic to consume more than 14 units per week. In England, an estimated 589,000 individuals are clinically dependent on alcohol. The Adult Psychiatric Morbidity Survey indicates that alcohol dependence peaks between the age of 35 to 44 and 45 to 54, while no participants aged 16 to 24 was dependent on alcohol, suggesting that severe dependence typically manifests after a prolonged period of harmful consumption. In 2023, there were 8,274 alcohol-specific deaths in England. This represents an increase from 2022. The total cost of alcohol harm in England was estimated to 27.44 billion in 2024. This is a figure that encompasses not only direct health service expenditures, but also the costs associated with crime, public disorder, social services, unemployment, and reduced workplace productivity. Within the population of individuals dependent on alcohol, the presence of co-occurring mental health disorder is the norm rather than the exception. 85% of individuals using alcohol have mental health problems. Anxiety and depression are usually the most common diagnosis, but severe mental health problems, including personality disorder and psychosis, are also common between drinkers. Individuals diagnosed with a common mental health disorder are more likely to report an alcohol use disorder compared to the general public. Within inpatient mental health settings, the rates of problematic drinking are profoundly elevated. 16% of screening patients in mental health hospitals consume alcohol at high risk levels, and 8% meet the criteria for possible alcohol dependence. Unfortunately, despite this profound comorbidity, access to integrated care remains a systemic failure. Among individuals in alcohol treatment expressing a mental health need, 56% report their only support comes from primary care, and only 2% report receiving support through formal psychological therapies. To effectively treat alcohol dependence, particularly when complicated by mental health problems, clinicians must understand not only how the biological mechanism maintain it, but also the psychological reasons why alcohol dependence began. The self-medication hypothesis is the main theoretical model explaining the psychological etiology of addiction. First formalized by Dr. Edward Kanzian, the self-medication hypothesis argues that the development of a substance use disorder is not a random behavior anomaly, a simple search for pleasure, or a manifestation of generalized self-destruction. Instead, dependence represents a targeted compensatory coping mechanism. Basically, a desperate attempt to self-regulate intolerable psychological suffering. Through extensive clinical observation, Kanzian identified that individuals who develop severe dependence fundamentally struggle with self-regulation. These vulnerabilities manifest in four primary domains: the regulation of emotion, the maintenance of self-esteem, the navigation of interpersonal relationships, and the capacity for consistent self-care. Such individuals frequently experience their emotional state in extremes. They are either entirely overwhelmed by intense painful emotion or unable to experience any emotions at all. Substances are therefore utilized to artificially relieve painful emotion or to force the experience of emotion when they are absent. A core principle of the self-medication hypothesis is that people don't choose their preferred substance at random. This is usually the result of a precise interaction between the psychopharmacological action of a specific substance and the unbearable emotion they are trying to manage. When we think about alcohol use, alcohol is a powerful sedative, and clients who gravitate towards heavy alcohol use frequently suffer from hyperarousal, severe anxiety, social phobias, or the hypervigilance, which is commonly associated with post-traumatic stress disorder. They discovered that alcohol's sedative and anxiolytic properties act as a powerful muting agent. By artificially depressing the central nervous system, alcohol temporarily sedates the hyperactive mind, lowers psychological defenses, and induces a state of artificial calm. Kanzian originally noted that, like opiate users who seek to mute the disorganizing effects of rage and aggression, alcohol users seek to quell rigid defenses and unmanageable anxiety. This is contrasted with individuals suffering from profound depression, hypomania, or low self-esteem who may preferentially select stimulants such as cocaine or amphetamine for their energizing, confidence-boosting properties. While alcohol might provide acute short-term relief from psychological distress, using it as a long-term self-medication initiate devastating psychological cycles that maintains the underlying problem and actually make it worse. Sedating anxiety with alcohol makes very hard for someone to tolerate it when they are abstinent. Empirical data confirm these hypotheses, given that many mental health clients report drinking alcohol as self-medication, and longitudinal data highlight that mental health problems usually precede alcohol dependence. But how exactly alcohol works? Alcohol acts as a strong depressant by simultaneously altering the brain's two primary neurotransmitter systems, the gamma aminobutyric acid, or GABA, and the glutamate. Alcohol exposure activates GABA A receptors, leading to sedation and motor impairment, while at the same time blocking glutamate receptors, suppressing the excitatory neurotransmitters in the brain. However, since the central nervous system is designed to maintain balance, in response to the sedative effects caused by alcohol, it will decrease the sensitivity and number of GABA receptors and dramatically increase the activity of glutamate receptors. This basically allows the individual to function with massive amounts of alcohol in their system, which is something we clinically call tolerance. The problem is that when a person trying to abruptly stop or dramatically reduce the alcohol intake, the sedation caused by alcohol goes away, but the hyperactivation of the brain remains. And that leads to what we call the acute alcohol withdrawal symptoms. Basically, this results in severe central nervous system hyperexcitability, which is manifested clinically through tachycardia, hypertension, severe psychological discomfort, profound anxiety, and marked physical tremors. Also, we need to consider that the brain response to withdrawal is not static. Every time a client starts a cycle of heavy drinking followed by immediate stop, the brain will become more and more sensitive, which is called the kindling effect. Basically, what kindling say that each successive episode of withdrawal lowers the brain seizure threshold and increase the severity and of future withdrawal symptoms. While a client that tries to stop drinking for the first time might experience mild irritability, if they keep engaging in these cycles of heavy drinking and sudden withdrawal, they will end up with life-threatening complications, including withdrawal seizures and delirium tremens. These basically should explain you why unmanaged and medicated detoxification is highly dangerous. The management of withdrawal often necessitates pharmacological intervention with cross-tolerant medication, such as long-acting benzodiazepine or anticonvulsant, to safely tackle the hyperexcitable nervous system, protect against brain damage, and halt the cumulative neurotoxicity associated with multiple withdrawals. Also, alcohol is a systemic toxin, which is capable of penetrating the blood-brain barrier and inflicting severe, often irreversible damage across virtually every organ in the system. The destructive capacity of alcohol is directly proportional to the volume and duration of consumption, with severe health consequences manifesting physically and cognitively. One of the most devastating and urgent neurological consequences of severe alcohol dependence is the Wernicke-Korsakoff syndrome. Basically, alcohol disrupts the absorption and storage of thiamine, which is commonly named as vitamin B1. And vitamin B1 is an essential enzyme required for the functioning of the brain. The subsequent severe thiamine deficiency triggers a severe neuropsychiatric disorder. In the acute stage, the Wernicke encephalopathy, is a life-threatening medical emergency caused by acute inflammation of the brain. It's usually characterized by a clinical triad: profound confusion and disorientation, oculomotor disturbances like unusual eye movements and double vision, and severe inability to coordinate voluntary movements. Because the classic triad is not always entirely present, any dependent client exhibiting even just one of these symptoms require urgent high-dose intravenous thiamine injection to halt disease progression. But if Wernicke encephalopathy is not treated, the acute inflammation of the brain will cause permanent lesion in the thalamus and hypothalamus and will become a chronic problem, which is known as Korsakoff syndrome. This syndrome is characterized by a severe permanent inability to form new short-term memories, while the long-term memories may remain partially intact. One of the clinical signs of Korsakoff is confabulation, a process whereby the brain fabricates false memories and stories to fill the gap and make sense of current circumstances. But clients also exhibit severe executive dysfunction, marked personality changes, extreme difficulty with risk assessment and problem solving, and loss of motivation. Alcohol is metabolized primarily via oxidation in the liver, where ethanol is converted into acetaldehyde before being further broken down and eliminated. Acetaldehyde is a group 1 carcinogen that causes direct damage to DNA molecules. It reduces cellular repair mechanism, increasing the risk of developing numerous cancers. But beyond its oncological impact, chronic alcohol exposure severely damages other vital systems. It does affect the heart by weakening, dilating, and causing rigidity of the heart muscle. It also causes irregular heartbeats. It damages the liver, including cirrhosis and hepatitis. It will severely affect the digestive processes and robs the body of vital nutrients. We have already seen vitamin B1, but it's also causing chronic gastric irritation and allows bacteria to escape into the bloodstream, potentially triggering sepsis. Chronic use severely suppresses both innate and adaptive immunity, increasing the risk of infectious disease and elevating the risk of acute lung injury following major trauma. When a person is presenting with a dual diagnosis, meaning the coexistence of a severe mental illness alongside alcohol use disorder, they will navigate difficult clinical reality. The interaction between these conditions increases the clinical risk and generates severely compromised outcomes across psychological, physiological, and social domains. Clients presented with concurrent mental health and substance use disorder usually experience high mortality rates compared to those presenting with just one disorder or the general public. If we look at meta-analytic data, they demonstrate that individuals with co-current diagnosis are twice as likely to experience negative treatment outcome, and these include relapse, emergency department visits, rehospitalization, and death. Unfortunately, the risk of suicide within this population is incredibly high, and this is because alcohol increases impulsivity, impairs judgment, and increases the effect of depression, which dramatically increase the likelihood of engaging in suicide attempts. Epidemiological data from the Office of National Statistics revealed that between 2007 and 2017, we had 5,963 suicides in England among mental health clients with a history of alcohol use, which basically means 542 deaths per year. And that accounts to roughly 10% of all suicide deaths in England. Also, the physical health of dual diagnosis client tends to be severely compromised, and the use of alcohol increases the risk of severe medical complication. The consequence of co-occurring diagnosis extend far beyond the individual's physical health and generates profound social instability. Clients who present with mental health problems and also use alcohol tend to be extremely vulnerable to multiple disadvantages. This includes poverty, social exclusion, unstable housing, and frequent incarceration. The 2009 Bradley report highlighted that coexisting substance use and mental health issue is the norm rather than the exception among offenders population. Another thing that we need to consider is that the presence of alcohol use and mental health disorder is highly correlated with interpersonal violence and critical safeguarding risks. Clinical reports and systemic investigation shows alarming rates of domestic violence and sexual exploitation involving dual diagnosis individuals. For clients who are parents or guardians, their ability to provide consistent and safe parenting to their children is often severely compromised, and this requires urgent child safeguarding and welfare intervention. Despite the profound complexity and risk profile of these clients, they tend to be usually failed by the clinical infrastructure. And this is because historically mental health services and substance use services were separated, which makes it very difficult to provide the joint care that this client needs. What happens is that usually mental health service require client to be abstinent or reduce their drinking before they can start treatment. At the same time, alcohol treatment services are not equipped to manage severe mental health problems or high suicidality or complex trauma as well. And this lack of integrated care results in highly vulnerable individuals being bounced back between agencies, experiencing care that is fragmented and dangerous for them. To try and avoid this, Public Health England introduced what is called the no front door policy, which means regardless of whether a client reach out to alcohol treatment service or mental health services, they should be working together to provide joint care to support the client. NICE Guidelines 115 outline phase protocols for identifying, assessing, and managing alcohol use disorder, particularly when it's complicated by common mental health conditions such as anxiety or depression. Because chronic alcohol intoxication and the subsequent withdrawal process organically produce profound depressive and anxiolytic symptoms, clinicians find very difficult to try and understand whether mental health problems are caused by an actual mental health problem or are the result of alcohol use. So what NICE guidelines says is that we need to have a stepping care approach. So the alcohol use should be treated first. In many cases, once a person becomes abstinent, their symptoms will go away because the brain will recover and the depressive and anxiolytic symptoms caused by alcohol should go away. However, if the clinical depression or anxiety remains after 3 to 4 weeks after someone becomes abstinent, at that point, that person will require some psychological or pharmacological support. For individuals who are using high quantity of alcohol and tend to drink a very high risk level, there is also a recommendation that they receive pharmacological treatment to manage the risk of complication and withdrawal symptoms. The problem is that not all alcohol clients presenting with mental health problems are ready to make changes straight away. They might not be ready to entirely stop their alcohol use, but they might be willing to try and reduce that. And the problem is that, as we know, alcohol dependence is normally caused by the presence of a mental health problem. So people fear that their coping mechanism is taken away without giving them the necessary support to manage their psychological distress. For this reason, my recommendation is that both alcohol service and mental health service start working jointly from day one. This will allow them to identify the client needs, see what the client is ready to achieve, and develop a joint plan to support to support the client. That should be the gold standard for treating clients presenting with both mental health and substance use problems. If we look at other countries, the American Psychiatric Association recommend pretty much the same, but they had that the client should be the center of their treatment. That basically means that clients should be consulted at every stage in order to decide what kind of changes they are willing to make and inform in terms of their needs and treatment plans that they might be requiring. To summarize, alcohol use and mental health are profoundly linked with each other. Clients tend to use alcohol because they need to cope with some sort of psychological distress. However, at present times, the access to mental health service for alcohol users tend to be quite difficult. Therefore, what is needed is more joint work to ensure that clients receive support from both services at the same time. Apart from this, I hope you enjoyed this short webinar and I hope you found it interesting. If you do have any question, please do not hesitate to get in touch. Thank you very much and have a lovely day.